Chairpersons.
Good
May I
afternoon,
kindly request all
respected
the
chairpersons, faculty and resident. I'm Dr. Avnish Katyare, senior resident at MC Rishikesh. Today I'm going to present my paper, a new trauma score, a severity score, a prediction of to predict morbidity and mortality in a polytrauma patients. And the co-authors are Dr. S.P. Mishra and Professor Jagmat Khanna from the Trauma Center, Super Specialty Hospital, BHU Varanasi. Uh, Start with the introduction. As we know that the high velocity vehicles has increased the incidence of road traffic accident, but the advancement of the newer technology, we have improved the outcomes in terms of mortality and morbidity in all polytrauma patients. As application of means advancement in CT scan, MRI, and DSA machine and the tech machine, so we improve the outcomes in terms of mortality. So we plan a study to predict the outcome in trauma patients in terms of morbidity and mortality with using of trauma severity score and comparison of trauma severity score with NISS and uh, revised trauma score. This was a prospective study of 506 patients from July 17 to June 18. A study was conducted at Trauma Center Super Specialty Hospital, BHU Varanasi. All patients of trauma were included in the study except patients who arrived after 72 hours or those who underwent a definitive surgical procedure or intervention for this trauma. These are the parameters we include in the study. General parameters and anatomical parameters. We divide the body into 7 parameters and physiological parameters, biochemical parameters, and general parameters for management, operative and non-operative, and final outcome we use for comparison cured, improved, and unchanged and expired for the outcome analysis. For the detail, I will discuss. Then we compare the outcome with the improved, cured, unchanged, expired with the injury severity score. We noticed that the 100% patients those are having injury severity score more than 50 were have 100% mortality, and those who have less than 16 was mortality is 0%. And in comparison with the revised trauma score, the mortality was those are having revised trauma score of 3.8. They're having highest mortality means as the score was less, the mortality is increased. And patients those are having higher scores. The 7.8 was having cure rate of up to 80% cases. So the results were seen to be significant. And so we used this. We derived multiple by using multiple parameters, anatomical, physiological, biochemical parameters. As we know that the new injury severity score and revised trauma score, we used a few parameters to combine all physiological and biochemical parameters also in the study. That we know that the physiological parameters, they are also important to predict mortality in trauma patients. So in anatomical parameters, we categorize the body in 7 parameters, and we give number that is called constant severity score, that is CIS, and this is a particular fixed number given to the anatomical regions, and then we calculate AIS for all regions and we'll multiply it. That is equivalent to anatomical trauma severity score. And physiological trauma severity score, we include 4 parameters, that is GCS, systolic blood pressure, respiratory rate, and grade of hemorrhage. That is almost they are equals to they include in as revised trauma score. We extra added hemorrhage, and hemorrhage was calculated as mentioned in the ATLS protocol. And biochemical parameters we used as pH, bicarbonate, and lactate, and we divide into the category as the scores the trauma patients. And we calculate the trauma severity score by combining all anatomical, physiological, biochemical parameters and divide into 4 category: minor trauma, major trauma, and severe trauma and lethal trauma. If it is less than 20, it's minor; 20 to 39 is major; 40 to 17 is severe; more than 80 or equals to 80 is lethal trauma. And we compare the parameters, and we reported that the patient those who have highest means in the lethal category, we noted 72% patient deaths, and patients those are having less less than 20, almost all patients were cured and improved, but none of the patients were died or unchanged for the treatment. And the p-value was noted significant. In conclusion, the injury severity score, revised trauma score, and trauma severity score. In new injury severity score, that notice that anatomical score always considered, but for calculation of prediction of mortality and morbidity, the physiology of the patient is very important. So this is the drawback of injury severity score, that they are only include anatomical parameters, which is the most commonly used for prediction of for severity of trauma. A revised trauma score is a more of physiological parameters. They do not include anatomical parameters. So basically, it's used for triaging a patient in a hospital, which is more severe. So if we include all parameters, including biochemical parameters, we included that in trauma severity score 7 anatomical reasons, 4 physiological parameters, and 3 biochemical parameters. That is used for better predictability of mortality in polytrauma patients. And if we use this one as a can be used, also used for triaging the patients. So for confirmation that this trauma severity score is superior to the NSS or revised trauma score or other trauma scores like
Dr. Avnish, your times is up. Please stop sharing. If any question from the chairpersons, please.
You have included all type of the patient. It is different. Make the difference of the making the score.
So we include all anatomical and
other children. If less than 5 year children you have included. If more than 80-year patient, if you included it, make the difference, or it is remain same.
That we need to study actually. Does the age is affecting or not? We
so
only use the anatomical.
If you doing some study, then there is a criteria.
Yes,
inclusion criteria. You have not mentioned any inclusion criteria. You have included
all types of patients, pediatric as well as elderly patients.
So it make the difference, na?
Yes.
It is not same for the pediatric age group. Even if there is a 2-year child come with some trauma.
Yes.
If patient is suffering from some comorbidity, diabetic, hypertension, that make the difference.
Yes, sir.
Requesting chairpersons to please proceed further for next presentation. Thank you.
So I invite next Dr. Devisa Agarwal to present your paper. Devisa Agarwal is here?
Yes, sir.
Yes. Yes, doctor, you can share your screen now.
A very good afternoon to all present here. Let me start by saying that facial injury is akin to a jigsaw puzzle, wherein our job as a surgeon is to carefully align the misplaced facial segments, just like solving a jigsaw puzzle. Today, I am going to present my experience in the management of complex nasal injuries from the Department of Otolaryngology and Head Neck Surgery, KGMU Lucknow. This management involves a precise mix of surgical suturing and loco-regional flap procedures for optimum results. So, have a look. Do we recognize her? Yes, she is the dream girl, Hema Malini, sustained nasal injuries sometime back in a road accident. She had to undergo cosmetic facial surgery for the same. So now we can see that facial injuries are very concerning and very common. No one can escape from them, not even celebrities. It is important to note that a nasal injury is seldom only a nasal injury. More commonly, it will involve other neighboring facial structures too. Now, the involvement of these neighboring facial structures, like the perioral region, like the eyes, is of concern because of 2 reasons. Number 1, obviously the functionality. And number 2, the cosmetic considerations after the injury. However, the good point is that the face has a very good blood supply, and that is a positive thing for the facial surgeon. So these are the basic surgical tenets of management of complex facial injuries that I have followed in my series of cases: early debridement, early repair, accurate alignment, immediate reconstruction, meticulous hemostasis, and obviously post-operative splintage. In brief, around 15 patients were reviewed over 2 years. All of them had nasal injuries involving the skeletal and the soft tissue framework. Wherever needed, local flap procedures were used. Skin was sutured. Sutures were removed on the 6th post-op day in order to minimize scarring. After repair of the facial unit, appropriate splintage was done, followed by proper scar management. Presenting before you a 50-year-old female who came with us with mutilating dog bite injuries involving the nose, the cheek, and both the upper eyelids. She underwent immediate meticulous debridement and surgical suturing under fine magnification. The results are in front of you. So this was a 30-year-old male who came to us with extensive lacerations and extensive crushing of the dorsum of the nose, the forehead, and the upper lip. He underwent meticulous wound debridement, repair of the lacerations, and the results speak for themselves. Over here, we have a 22-year-old man. He came to us after an accident, initially went to a peripheral hospital, presented to us with bad suturing of the nose, the forehead, and look, the left ala of the nose is missing. He underwent immediate wound debridement and revision of the lacerations. Also, the left ala of the nose was reconstructed using primary forehead flap. So, we must understand that facial injuries are unforgiving because the quality of the repair shows clearly on the face of the patient. That is why it is important to perform early repair with adequate debridement and to do whatever you want to do as much as possible in the golden period of injury. Immediate flap reconstruction of any missing tissues followed by accurate alignment. So, to conclude, I would like to say that success in the management of complex nasal injuries lies mainly on 3 pillars. Number 1, follow the surgical principles of repair. Number 2, whatever part is missing, reconstruct it. Number 3, appropriate splintage after operation for at least 2 weeks after injury. So, in order to put as an end to my presentation, I would like to say that nose is an important facial landmark that God has gifted us. And as a surgeon, it is our job to try to preserve it to the maximum. Thank you.
Any question from chairpersons?
Devisha, you mentioned about flaps.
Yes, sir.
What sort of flap you use apart from local and local flaps and rotation flap? Do you ever use free flap or for the because sometimes there is a major loss from the facial region. So do you ever use free flap?
Thank you so much for the question, sir. So we have used only the local flap and the rotational flap because of many reasons. First of all, for the nose, the main thing is the cosmetic appearance. If we use a free flap, the skin obviously will not match with the facial skin and it will look really bad. So the gold standard is the forehead flap. Also, the nasolabial flap is used. But in my cases, I have used the forehead flap everywhere. And for minor local tissues repair, local rotational flap was used. Mainly these 2 types of flaps were used.
Devisha, it's Vignesh here. So I just wanted to know, do you recommend early reconstruction, meaning immediate reconstruction in all your patients, or you would say an early debridement followed by a reconstruction after 24 hours or 48 hours would be your way to go forward with this?
Thank you so much for the question, sir. So I would recommend immediate debridement, immediate repair, and early reconstruction within 24 hours because better results have been seen, and it is always better to practice it is always better to practice and be a very swift person in this regard, as the results have always been better.
Devisha, please excuse me, I will have to interrupt you because we are bound by time. Thank you so much. That was a wonderful presentation. And may we now have on board Dr. Digvijay Patil. Dr. Digvijay, kindly share your screen, and he will be presenting his work on prospective observational study of 3D CT evaluation in femoral tunnel positioning. Dr. Digvijay.
Dr. Divisha, please stop your sharing. Please stop your sharing screen. Presenters, when you completed your presenter, please stop sharing so that we can allow next presenter to stop to share screen.
Good afternoon all. Today I am going to present you a prospective study of 3D CT evaluation of femoral tunnel positioning in anatomical single bundle remnant preserving ACL reconstruction using outside-in technique. The ACL is the key structure in the knee joint as it resists anterior tibial translation and rotational loads in the knee. Extended, the ACL has a mean length of 32 mm and a width of 7 to 12 mm. Anatomical ACL reconstruction is a favorable approach for superior clinical outcome and better kinematics. The most important point in anatomical ACL reconstruction is placement of the femoral tunnel and tibial tunnel in anatomical site. In addition, preservation ACL remnant is suggested to improve vascularization and proprioception function of the graft. Outside-in drilling technique allows independent creation of the femoral tunnel. Outside-in drilling technique allows femoral socket to be drilled with knee in 80-degree flexion without need of knee hyperflexion, thereby improving visualization of ACL femoral footprint from anterior portal. During this method, visualization done from anteromedial portal, which gives better visualization of the posterior part of the ACL footprint. Material and methods. Patients diagnosed as having mid-substance tear ACL and treated at our institute between January 2018 to March 2019, and those were followed in outpatient department were studied prospectively. We could study 12 patients who fulfilled our inclusive, exclusive, and follow-up criteria. X-ray and MRI were performed in all patients. X-rays are done to rule out any Sigon's fracture, and MRI to rule out other any soft tissue injuries or ligamental injuries. On physical examination, all patients had effusion, tenderness along the medial joint line, painful range of motion, anterior tower test, Leishman test, powered shift tests are positive. These are the images of MRI showing the ACL tears, coronal and surgical techniques. Patient's position supine with knee 80-degree inflection under spinal anesthesia. Arthroscopic evaluation of knee is performed using standard anteromedial and anterolateral portal. Knee kept at 80-degree flexion. Arthroscope is introduced through anteromedial portal. Through anteromedial portal, there is a good view of posterior aspect of ACL femoral footprint. The outside-in femoral guide is inserted through anterolateral portal and its tip is placed at proximal anterior part of ACL footprint. Retrograde trimming of the femoral tunnel is performed with a retrograde trimmer of appropriate diameter of the length of 20 mm. Tibial tunnel is prepared by standard manner at the center of tibia footprint, while care is taken to preserve the remnant. After making femoral and tibial tunnel, hamstring autograph is passed through the tunnel. A suspensory device is used for femoral graft fixation, and an interference screw is used for tibial fixation. After this, we will done in 3D CT of the patients in first week. In order to evaluate femoral tunnel, the scan is oriented in the true lateral view. The Blumenstedt's line is then marked. The medial femoral tunnel condyle is then digitally subtracted until the root of the notch was superimposed on the previously marked radiologic Blumenstedt line. The position of the femoral tunnel is evaluated using Bernard and Hertel method. The position of femoral tunnel is determined as a percentage of the depth of the notch as a percentage of the height of the notch. The mean position of femoral tunnel in this study is then compared to the optimum position, which is determined by knowing the mean coordinates reported by the previous study. These are the pictures showing the how to calculate the depth and height of the femoral tunnel. Results: the total 12 patients underwent ACL reconstruction during this study. Patients were eligible for inclusive criteria on the basis of 50% of graft coverage by remnant at the end of the surgery. Intra and inter-observer results were excellent. According to the quadrant method, femoral measurement, the center of mean position was at 17.4% of the depth from Blumen's line and 22.1% from the of height. All the femoral tunnel were continuous and no posterior cortical blowout was observed in any patients. These are the studies I will compare with these. So my studies have Samba technique. It is about close to this 17.4 for depth and it is 22.1 from height. So on conclusion, our study results were close to the Samba technique study, so that the femoral tunnel placement by this technique is precise and consistent. Limitation of this study is that no control group and presence of large ACL stump had any influence on tunnel placement. Further comparative studies were required. Three-dimensional CT evaluation demonstrated that despite presence of ACL remnant, placement of femoral tunnel for anatomical reconstruction is more precise by this technique. During outside-in drilling of the ACL femoral socket, a guide pin entrance angle of 60 degree to a line perpendicular to femoral anatomical axis combined with a guide pin entrance angle of 20 degree to the trans-epicondylar axis resulted in the closest approximation of the gold standard of the normal anatomical morphology of the human knee. ACL femoral footprint length, width, area, and angular orientation. Thank you.
Well, Dr. Digvijay, I'm sure that is quite an interesting work, but unfortunately, I'm not an orthopedician, so I'm not able to comment much on it.
Okay.
The house is open to questions by other panelists and other participants.
Digvijay, Vignesh here. So I just wanted to know, apart from not having a control group, what else do you consider as limitations of your study, and what else would you consider as strengths of your study?
It is large remnant of the graft. If they are present, then it is the another limitation, and others I don't see.
Okay, it's time for the next presentation. Thank you so much, Dr. Digvijay.
Thank you, sir.
The next presentation will be on abdominal compartment syndrome in non-emergency laparotomy, and the early management prevents a catastrophe. This will be by Dr. Ganesh. Dr. Ganesh, if you can share your screen and you can start.
Good afternoon, Chairperson. I'm Dr. Ganesh from KM Hospital, Mumbai. I'm here to present on the abdominal compartment syndrome in emergency laparotomies. As we know, abdominal compartment syndrome is very common in trauma, but we decided to study this in all emergency laparotomies. Basically, compartment syndrome, it is a condition in which pressure within the compartment increases to such an extent to compromise the vitality of tissue within. World Society for Abdominal Compartment Syndrome are formed in 2004, and which given a following definition. Intra-abdominal pressure is a steady state pressure concealed within abdominal cavity, which is normally 5 to 7 mm of Hg. If it is more than 12 mm of Hg, it is called as intra-abdominal hypertension. And if it is more than 20 mm of Hg or associated with organ failure, it is called as abdominal compartment syndrome. Aim of the study is to study the incidence and outcome of a IH and ACS in patient undergoing emergency laparotomies and its correlation with systemic morbidity in terms of SOPA score, ICU admission, and hospital stay, as well as a local morbidity in terms of burst abdomen, sutured instance, and in-hospital mortality. Study is conducted at a KM hospital, which is a prospective observational study with 34 patients. Patients are included considering inclusion and exclusion criteria. Then we taken a consent, history examination done, necessary investigation done, and we calculated the IAP and SOPA score pre-operatively prior to shifting to the OT, and at 6 hours, 24 hours, 48 hours, and 72 hours. Then we calculated the total hospital stay and mortality and morbidity noted. We measured intra-abdominal pressure using locally designed device based on YouTube manometry principle, and we calculated the SOPA score based on the basis of this table. 28 patients out of 34 patients are of a perforative peritonitis, out of which 3 are traumatic perforations. Other patients are 3 are of hemoperitoneum, 1 is for IBD, 1 is for intestinal obstruction. Out of 34 patients, 7 developed abdominal compartment syndrome and 20 developed intra-abdominal hypertension, in which 4 have a grade 1 IH, 8 has a grade 2 IH, and 8 has a grade 3 IH. Outcomes in IH patient. As we see in the graph, rate of ICU admission goes on increasing as a grade of intra-abdominal hypertension increases. 2 out of 14 normal patients requires ICU admission. In contrast to that, 7 out of 8 grade 3 IH patients require ICU admission with p-value of 0.002, which is a significant. Similar trends are observed in a mortality. In the mean hospital stay, burst abdomen and dehiscence, the p-values are not significant. Comparison of SOPA score with IH is found statistically significant at every point of time. Mean hospital stay of the patient are 11.22 days. Outcomes in patient of ACS. In ACS, 7 out of 6 patients required ICU admission. 6 out of 7 patients are died, which is a statistically significant. And in ACS also, mean hospital stay, burst abdomen, and dehiscence is not significant. This is a measurement of intra-abdominal pressure with the time. Here are the conclusion. IH and ACS is more common condition than recognized previously in patient undergoing emergency exploratory laparotomy. In patient undergoing emergency exploratory laparotomy, the correlation of IH and ACS with SOPA score is statistically significant. Rate of ICU admission increases with increase in a grade of IH, as well as it is more in ACS patients. The association of ACS and intra-abdominal hypertension with occurrence of local morbidity, that is burst abdomen and suture line dehiscence, is not statistically significant. Incidence of mortality in patient with EEL increases with increase in grade of IH, and development of IH and ACS is a strong predictor of the mortality. These are the p-values for the conclusion, and these are the tests we used, and all of these are found significant. Thank you.
Thank you, Ganesh, for sticking to time. I just have one question. How many of your patients with, could you just elaborate, how many of your patients with increased IH or abdominal compartment syndrome required re-exploration, or how did you manage them?
So it was an observational study, so we didn't consider the management of these patients. Okay,
thank you. Any other questions from the other co-chair?
Dr. Ganesh, which is the best method to measure the intra-abdominal pressure?
Sir, urinary bladder methods.
So, what are the other methods to measure the intra-abdominal
pressure? Other methods are we can use the intragastric pressure, then you can measure the IVC pressure, then the rectal pressure. Then we have devices which are inserted into peritoneum, where we can directly measure the intra-abdominal pressure.
Okay, now I would like to invite Dr. Jogendra Bodheda for a topic on pattern management and outcome of traumatic neck injuries at the level 1 trauma center. So Dr. Jogendra, kindly start sharing your screen.
Yes, sir. Is my screen visible?
Yeah, it's visible. You can proceed.
So, good afternoon, all panelists. Today I'm going to present about the pattern, management and outcome of traumatic neck injuries experienced at our level 1 trauma center. Myself, Dr. B. Jogendra, from the Division of Trauma Surgery and Critical Care from JPN ATC. So traumatic neck injuries constitute around 5 to 10% of all the trauma cases according to the previous review of literatures. And these injuries can be caused by either penetrating injury and blunt trauma. These penetrating injuries mainly caused by the stab injuries or gunshot injuries or self-inflicted either suicidal intent and manja thread injuries. And blunt trauma mostly caused by the motor vehicle crash or assaults or fall from height. The management of these traumatic neck injuries in emergency department, these are life-threatening injuries which required an immediate attention and interventions required on the part of emergency physician and the trauma surgeons which will be present in the ED. And the initial management in the ED is followed according to the ATLS guidelines, airway, breathing, circulation, and in airway whether the patient is able to maintain the airway, whether there is any open wound is present in the neck or not, and placing an ET tube in the open wound, or whether the patient is able to maintain secure airway. And after initial management stabilization of the patient in the emergency department, this was the algorithm for imaging of the neck injuries. Neck injuries, we will divide the patients into two patterns, stable patients and unstable patients. The unstable patients were directly taken to the operating room. And the stable patients, depending on the mechanism of the injury, whether these are the penetrating injuries or blunt injuries. The penetrating injuries, the patient will be gone for CT angiography with the suspected esophageal injuries will be taken for CT esophageograph at the same time. And in case of blunt injury patient, whether the patient had any significant injuries present or not. If there were no significant injuries present in case of blunt injury, then patient will undergo for USG Doppler neck to rule out any vascular injury. If there is a significant injury is present in blunt trauma cases, then CCT neck as a part of CCT torso will be taken care of. If suspected esophageal injury in the blunt injury also, we will go for CT esophagogram. So what is our experience? This is about a retrospective observational study which is conducted at the Division of Trauma Surgery and Critical Care from January 2016 to March 2020. This data was retrieved from the computerized patient record system. And this total 130 patients were admitted with traumatic neck injuries were included. Now the table 1 which shows the mechanism of injury, signs, presentation at the time of ED and involvement of the anatomical zones. The mechanism of injury, most common mechanism is the assault, that is with homicidal intent, more than 40% of cases or assault. And the self-inflicted injuries constitute around 18% of the cases, and road traffic injuries also presenting constitute around 23% of the cases. And the rest are accidental gunshot and Now, what is the presentation at the time, presentation to the ED? There were maximum around more than 50% of the cases they are presented with open wound in the neck, and there was around 20% of the cases present with active bleeding, and presence of shock is also one of the presentation to ED. And around 20 patients they had a air leak was present from the wound. And what is the zones involved? The most common zone involved is the zone 2. Around 83% of the cases are zone 2 involvement, and zone 1 was 16 patients, and zone 3 was 5 patients were present. And what is the operative procedures and intraoperative findings? Around 46%, around 50% of the cases, these are 60 soft tissue injuries were really present. Presence of skin, subcutaneous tissue, strap muscle involvement, sternocleidomastoid muscle or trapezius muscle cut involvement was present. And in case of 37 cases, 21 are thyroid and 16 are tracheal injuries were present. Around 35% of the cases were these laryngotracheal injuries were present. And vascular injuries were present in around 18% of the cases. IJV, EJV, carotid artery injuries were present, and rest of the cases of around less than 10% of the cases. And what is the most common operative procedure done? In this soft tissue injuries, soft tissue primary repair was done, and the repair of the laryngotracheal injuries was done in 37 of the cases, and repair of the IJV was done in 9 cases, and ligation of the internal jugular vein in 7 cases. Cervical esophagostomy was done in 6 patients, and the rest of the patients underwent repair of thyroid membrane and repair of floor of the mouth and parotid gland. These are the showing operative procedures. Now coming to the outcome of the patient. Outcome, what is the length of the hospital stay and what is the mortality. In total, 118 patients were discharged. Out of the 130 patients, 180 patients were discharged within less than 3 days for 54 patients. Most of the patients, these are involvement, only soft tissue injuries were present. And rest of the patients are more than 3 days, 3 to 7 days, 28 patients, 8 to 14 days are 17 patients, more than 14 days are 19 patients. Most of the patient involvement is presence of aerodigestive injuries. The aerodigestive injury patients are longer hospital stay. More than 1 week to 14 days or more than 14 days were present in around 19% of the cases. And coming to the mortality, 12 patients were expired during our study period, out of which 2 are due to hemorrhagic shock and 6 patients are due to septic shock, mostly involving the esophageal injuries. As this patient, out of 6 esophageal injuries patients, 4 were referred cases from outside, which came after more than 3-4 days after the injury, resulting into the septic shock and patient leading to the mortality of the patient. And other associated injuries were 4 patients were present, including head injury as one of the cause for these other associated injuries. So coming to the conclusion, traumatic neck injuries, they are mostly associated with the aerodigestive tract injuries. They have the increased length of hospital stay and associated with also increased mortality. So the algorithm which was shown has a best helps in the better outcome of the patients in treating the patients with traumatic neck injury. So I would like to show. Yes, these are some of the pictures. Thank
you. Kindly show your screen. We are not able to see.
Majid, his time is over. You can ask. You can go with question answer.
He is completed. My question to you is, like you said, airway management is one of the prime thing. But apart from airway, what is other injuries that can happen in a neck injury? I mean,
vascular injuries are the next most.
Okay, vascular injury. You did not mention about protecting cervical spine during airway management.
Yes. So in airway, at the time, only protecting cervical spine also. C-spine stabilization is also one of the part of the airway.
Yeah.
Yes.
Any other question from the chairperson?
Dr. Joginder, what was the prevalence of cervical spine injuries in this cohort? Dr. Joginder?
Yes, sir.
What was the prevalence of cervical spine injuries in this cohort?
Cervical spine injuries, there were only 4 patients out of these 30 patients. In 130 patients, there were only 4 patients with cervical spine injuries were noted in my study.
And what was the nature of deficit?
Hello.
What was the nature of deficit?
Hello.
What was the nature
of
deficit, neurological deficit?
Yes, sir, present with neurological deficit, yes.
Hello. Now I invite Dr. Mahesh Sethi to present the paper on comparison of surgical site infection between negative pressure wound therapy, assisted delayed primary closure, and conventional delayed primary closure in grossly contaminated emergency abdominal surgery, a randomized controlled trial. Dr. Mahesh Sethi, please present.
Yes, ma'am. Good afternoon. Thank you, ma'am. Good afternoon, everyone. Starting with my presentation with the title of comparison of surgical site infection between negative pressure wound therapy, assisted delayed primary closure, and conventional delayed primary closure in grossly contaminated emergency abdominal surgeries, a randomized controlled trial. So, surgical site infection really a heavy burden over the patient as well as all the healthcare system by increasing the length of stay and also by increasing the wound-related morbidities. So negative pressure wound therapy has been tried over last decade to which shown to be improving the wound healing by reducing the seroma formation and also by decreasing the surgical site infection rates. So previously, the negative pressure wound therapy also has this has been shown to decrease wound complications in both elective and emergency combined. But however, there is no study has been done to see the efficacy of negative pressure wound therapy exclusively in the emergency laparotomy cases. that is grade 4, class 4 wounds. So with the research questionnaire, can prophylactic negative pressure wound therapy helps in decreasing the surgical site infection in class 4 wounds after emergency laparotomies? So with this, the study was started, which was an open randomized controlled trial, which was conducted in Bhubaneswar, with 43 sample size in each arm, with reference article which was published in Annals of Surgery in 2017, which includes only class 4 dirty wounds who underwent midline laparotomies and patients of age more than 18. So all the patients who underwent, who included in this study, the skin was laid open in post-operative period. So on post-operative day 1, in conventional arm, the skin was laid open and it was continued till post-op day 5. And after post-op day 5, the skin was closed. In negative pressure wound therapy arm, the skin was laid open in post-operative period. The negative pressure wound therapy was applied on post-op day 1. This is the machine which is showing the negative pressure wound therapy. And on post-op day 5, the dressing was removed and the skin was assessed and closed. So the primary objective of my thesis was, so this is a surgical site infection, to see the surgical site infection within 30 days of surgery after closing the wound. And in secondary objectives, we have seen rate of hematoma, seroma formation, sheath dehiscence, and burst abdomen within 30 days. And also we will see for hospital length of stay. So total 51 patients were recruited eligible for the study, out of which 13 were excluded, and after 38 of inclusion, 21 in negative pressure wound therapy arm and 17 in conventional arm. So without any exclusion, the sample size was analyzed. So with analysis, the primary outcome of surgical site infection after 30 days. So there are 4 surgical infection rates in negative pressure wound therapy arm and 3 in conventional arm, but without any significant difference. Also, there are no significant difference in secondary outcomes like in seroma formation, hematoma formation, sheath dehiscence, burst abdomen, and also in length of stay. So with this, the contrary, which has been proven previously, the negative pressure wound therapy decreases the surgical site infection in delayed primary closure wounds. However, in my study, there is no significant difference in decreasing the surgical site infection by negative pressure wound therapy dressing in comparison to delayed primary closure. So, but with this ongoing trial, the final conclusion yet to be concluded after completion of the study. So the limitations I have faced in my study was cost effectiveness of the materials which are used in negative pressure wound therapy dressing, mainly the sponge and machine. And also with the negative pressure wound therapy, there is a limitation in the ambulation for the patients. Also, there is a patient had to stay compulsorily for post-op day 5. And also there is a decreased compliance with the negative pressure wound therapy. Thank you, ma'am.
Dr. Mahesh, where you register RCT?
So in Indian clinical trial, sir.
Okay. So you have shown one chart in that your study. What is that called actually?
So, sir, let me see.
You have shown one flow chart, na? Inclusion, exclusion.
This one, sir?
Follow up.
So this one, sir?
Yes, this one. What is it called?
Sir, consort diagram, sir.
Okay.
Have you faced any patients where you have lost a follow-up?
Sir, difficulty lost to follow up, like the patient is not able to come to the hospital. So in that scenario, we used to call the patients and we used to assess the wound also. Like over the phone call from the hospital, we followed the patients. We have also WhatsApp groups, sir. They are sending photos, like wound photos, they are also sending in them.
Sure, thank you.
Thank you, sir.
Okay. Dr. Mahesh, stop your sharing. Next presenter, Dr. Abdul Rahim. Please start your presentation.
Dr. Abdul, please start your presentation, share your presentation.
Dr. Tul, yes, he is. Yes,
Yes, just starting.
yes.
A very good afternoon to everyone. So my topic today is on resuscitative thoracotomy, an ED perspective. I'm one of the doctors working in Southampton General Hospital in the United Kingdom, and my special interests are on trauma and pre-hospital care. So one of the main reasons I got involved in this topic, or I took more interest on this topic, is because of a few of the cases that I've dealt in the last few years. And so in my own hospital, we've done an audit, and we have come across various different protocols which would suit best for this region. So this is a simple audit that we conducted in our own hospital for the time period between 2012 and 19. So we had around 72 patients who underwent thoracotomy or thoracostomy. And I just wanted to see what were the outcomes and what were the reasons why certain patients had certain good outcomes and some patients didn't have certain outcomes. So we saw that there were in great outcomes in resuscitative thoracotomy in the emergency department, and there were some reasons for it, which I'll come to in a minute. So this data was collected from TARN, the Trauma Audit and Research Network. And as we see, there were 4 major thoracotomy. There was resuscitative thoracotomy conducted in the ED, 1 was done in PICU. And all the non-cardiac arrest causes of thoracotomy, they all survived. But those who underwent cardiac arrest, they were in great outcomes. These were the 4 main cases that I focused on. There was a pedestrian, there was an RTC by, on a 71-year-old male, there was an assault, chest injury, and there was an RTC again. All of this, the outcomes for all of these patients were that they all died, but there was a reason for it. And the more we explore into it, we find that the common factor for the bad outcome was because of the delay in the pre-hospital intervention, as well as the decision-making in the hospital. One of the recent cases which I was involved in earlier this year was a 17-year-old boy who was stabbed to the right side of the chest, was brought in with a non-recordable blood pressure, a heart rate of 58, with an end-tidal of just 2.1. He lost his output within 2 minutes of arrival to the emergency department, and followed by, we did a thoracostomy bilaterally, and then we converted that into a clamshell thoracotomy. He had the blood transfusion as well as cardiac massage, which improved the end-tidal to 4.4. Eventually went to the operating theater, where the bleeder was found to be the right internal mammary artery. But unfortunately, after a few hours, around 4 to 5 hours in the theater, he couldn't make it. So following that, this was one of the revised guidelines following the RCS, the Royal College of Surgeons, as well as the Resuscitation Council. We saw that what is the best way of actually going forward with resuscitative thoracotomy in the emergency department. As we see, the best survival is always found in the penetrating trauma, who've lost the vital signs within 15 minutes. And the worst outcome is always at blunt trauma. And very, very few survivors in the whole world where we see they were blunt trauma and they've had a good neurological outcome. We primarily depended on the cardiothoracic surgeons to be present, but in certain scenarios, if they were not, or they were involved in other cases, then we encouraged and also made sure there were trained personnel in the emergency department who could conduct the resuscitative thoracotomy. This is the Standard Resuscitation Council UK guideline algorithm for traumatic cardiac arrest. As we see, there hasn't been much of a change. Even in 2020, there hasn't been much of a change. They're following the same guidelines, that in unwitnessed cardiac arrest or an apneic or a pulseless cardiac arrest, there wouldn't be much of an outcome with resuscitative thoracotomy. And There are some exceptions for pregnancy where the patient should be transported and a resisted hysterotomy to be considered. These are a few tips which we made for the residents to follow. Top 10 tips for the resisted thoracotomy. The best outcome was always found to be with a clamp found was, we need a very simple SOP, a standard operating procedure with minimum number of items in your thoracotomy box. The more the items, the more the complications. The user usability is very difficult. So all we actually need is a scalpel, a jiggly saw if needed, a large scissor would be enough to start off a thoracotomy. And also clamping the aorta. Okay, it could be, it's a very necessary step right after you open the chest and after you initiate the cardiac massage, so that you improve the myocardial flow, improve the myocardial blood flow by clamping the aorta. In summary, the learning points from this audit and from the case series that we saw was that there's a recognizing need for assisted thoracotomy early on, minimizing the instrumental use for the clamshell thoracotomy, and to train doctors and paramedics with needle decompression. So in those cases, you see, if the needle decompression were done early on, the tension pneumothorax could have been relieved, as well as in some centers, like in London and other places where they do finger thoracostomy early on. And if they have the ability, you can do a pre-hospital thoracotomy, but at least a finger thoracostomy pre-hospitally does improve the survival outcome. And as I noticed that
okay, Nabil, I have a question.
Yeah.
Do you use this thoracotomy in penetrating non-thoracic trauma? Do you ever use like in abdominal or in extremity where the patient has bled a lot?
Yes, we can use it if you want to cross-clamp the aorta. So if we suspect there's a major vessel.
But the thing is, Reboa is also there. So do you prefer open thoracotomy over Reboa, or you do? What is your guideline there?
Yes, so Reboa is used, yes, for, as you mentioned, for the abdominal trauma, Reboa is used. But again, Reboa is more reserved for traumatic injuries rather than like pelvic injuries, where it is of more of a use. Like a zone 3 Reboa for pelvic injuries, more of a use than a clamshell thoracotomy.
Thank you so much, Dr. Nabil. That was a wonderful presentation indeed. Now let us have Dr. Neeraj Kumar, and he will be talking about his experience in predicting clinical outcomes using albumin and C-reactive protein. Dr. Neeraj, kindly share your screen.
Dr. Neeraj, can you hear us? Please share your screen. We are not able to hear you, Dr. Neeraj.
Good afternoon, everyone. The screen is visible, sir?
Yes, please proceed.
Okay, sir. Good afternoon, everyone. We all sitting here on deals with the polytrauma patient on day-to-day basis and faces a problem in our ED while assessing severity of the trauma patient and predicting the outcome. These mainly this assessment mainly depend upon I'm not able to change the slide. No, okay. These mainly this assessment of the severity and the predicting the outcome mainly depend upon the clinical judgment what we do in our ED, like assessment of the injury severity score that is most commonly used in emergency room. But if there is any scale that involves the objective parameter, more accurate assessment of the severity of the injury and the outcome can be made easily. And that can affect the early part of the management. So therefore, this study basically focus on the this study has aim of to find out the correlation of the albumin and the CRPH as an indicator of the trauma patient, as an indicator of the trauma severity and Apache. And second one is to assess the albumin and CRPH as a predictor of the outcome. We did a study, that is a prospective study at the trauma center in Rishikesh, and that included around 156 patients from July 2018 to 2020. And in this study, actually, a polytrauma patient who presented within 24 hours the injury with the injury severity score of more than 15 were included, of the age group 18 to 65 years. The patient who excluded were those who are expired within 24 hours of the injury, or the patient in which the other comorbidity condition were affecting the level of the albumin, like the pregnancy, liver disease, and the malnourishment. For the study purpose, we collected, after taking the the blood sample on the time of the admission, at 12 hours, at 24 hours, 48 hours, 72 hours of the injury, and of the admission, sorry, and the kinetic of the albumin and CRPH was drawn. For the kinetic, we observed the absolute value, the change in the value, the percentage change in the value of the albumin as well as the CRPH, and we found the correlation with the outcome. And these outcomes were the injury severity score. One is the Apache score, other is the SIRS, other is the ICU admission, ARDS, MORS, as well as in hospital mortality. When we assess the kinetic of the albumin and CRPH with the injury severity score, then we found there was a positive correlation of the serum albumin level with the injury severity score. And these values that were related to the injury severity score were at the time, at the 12 hours of the admission, at 24 hours, 48 hours, 72 hours. And the value of the albumin that were present at the time of admission was not found to be associated with the injury severity score. And as far as CRPH is concerned, it was and none of the value of at any time was found to be associated with the injury severity score. And also, there was neither of the albumin nor of the CRPH was found to be associated with the Apache 2 score.
1 minute left.
One is the albumin. We also found the association of the albumin with the SIRS, and we also found the association with the ICU admission. The ICU admission at the time of the at the 12 hours of the admission, we found that the percentage change in albumin of -17 was found to be having significantly associated with the injury severity score.
Thank you, Neeraj. We may proceed with the questions, please.